네, 안녕하세요. 상해 의사입니다. 제가 미국의 미용설과 학회 또 인터내셔널 멤버기도 하거든요. 그래서 이번에 2025년 3월 달에 미국의 텍사스 오스틴에서 열리는 학회에서 작은 발표가 하나 있어서 프레젠테이션을 준비했는데 이제 그중에 사진이나 동영상은 좀 빼고 좀 간단하게 축약해가지고 파일을 공유해 볼까 합니다. 관심 있으신 분은 좀 보고 어떤 인스퍼레이션을 좀 얻으실 수도 있을 거예요. 네, 프레젠테이션 시작하겠습니다.
Good morning. I'd like to share my experience about anterior layer of levator surgery and introduce a simple non-incision technique. My congenital surgery journey spans over 20 years, particularly in Vietnam, where our team performed more than 3,000 surgeries for children with cleft lip, palate, ptosis, and hand anomalies through the Smile for Children initiative and Operation Smile team. Through this experience, I got the insight for levator anatomy. One day, I found an undetermined layer on the surface of orbital fat, and it was elastic and continued to levator palpebral muscle. After came back from Vietnam, I found two articles about this anatomy. This raised a pivotal question. What if our fundamental understanding of levator surgery was incomplete? Cleft palate palatal muscle reconstruction, cleft lip orbicularis oculi muscle reconstruction, and why we have been doing shortening instead of reconstruction in ptosis surgery. Really, there is anatomical attenuation. I also found out some similarity between palmaris longus and levator palpebral muscle. Their morphology is similar: long and narrow muscle, and change it to aponeurosis and retinaculum. Their aponeurosis is composed of two layers, and function is also somewhat similar. I established this concept. In normal patient, anterior is going down to tarsial plate, but in ptosis patient, anterior is misinserted to flow orbital fat. It can be compared to four-wheel drive vehicles. My technique is simple. Find the caudal margin of anterior layer and turn down to posterior layer. Elevate posterior layer from anterior surface of tarsial plate. Finally, suture two layers and fixation on tarsial plate. It was published in 2000. Anterior relocation technique has several advantages. Among them, avoiding leg ophthalmos is biggest advantage. Most patients had frontalis sling or CFS sling surgery suffered from leg ophthalmos for quite long period. But this technique is somewhat difficult. Therefore, I introduced easy non-incision technique. Indication mild to moderate ptosis case. I'm gonna show short video and you should notice two things. One is vascular arcade and second is volume after conjunctival stitches. Conclusion: levator aponeurosis has two layers like palmar aponeurosis. Anterior and posterior is fused around the retinal ligament. In ptosis patient, anterior misinserted to undersurface of the fat. In mild to moderate case, non-incision technique can be available and secondary arcade of vessel is landmark of anterior layer. Anterior layer is obvious anatomy and has function. enrich dermis of skin and makes double fold and prevent sagging of orbital fat and reinforce posterior. Thank you. Thank you for your attention.